Dr. Rahul Dev Sarkar. I am a consultant in respiratory medicine and intensive care, currently practicing in the UK, and I have been asked to present to you about the basic principles of ventilation and issues around ventilation that might be relevant for EDIC Part 1 examination. And I try to cover some of those issues in the next few slides, which will probably cover between 45 minutes to an hour at the most. And I am not obviously claiming that it will cover all issues surrounding ventilation, and I will not discuss any evidence base or any particular deeper areas of ventilation. I will try to cover as much is required probably for the exam. And if there is any other question, I can answer later on by email. So to start with, sometimes some of the questions and some of the issues, some discussions might allude to the basic difference of ventilation and oxygenation, which I certainly have seen that some people have a slight issue in the concept of the difference between these two. So I'm just mentioning, I'm sure most people have very clear idea. Ventilation is movement of air in and out of lungs, which is either through negative pressure, which is obsolete now, or positive pressure ventilation. Oxygenation is purely diffusion of oxygen across a membrane into the blood. This concept obviously has to be very clear, and we know that oxygenation is possible without ventilator at all through ECMO. So this is the basic circuit, and I'll come back to that later on. There's quite a few sensors available, and computer and expiratory valve, and eventually it is connected to the endotracheal tube, which pushes air inside the lungs. And the basic modes, there are lots of different names from various companies, as we all know. I think for approaching any particular question, if we can keep our mind clear as to what basic generic mode the patient is on in the particular question, then it becomes quite a bit easier, instead of trying to be bogged down with all the trade names that various companies have. So as we all know, it is going to be divided in control mode and support mode. And in control mode, there's so many other varieties, some mixed modes where the support assisted breaths can be mixed with controlled breath, etc. But for basic classification, I think we just need to stick to this paradigm: control mode and support mode, and both can be either volume control, pressure control, and similarly volume support and pressure support. So whenever we are thinking of any particular question, this is what we are going to be basing our thought process around. And this is important, that various different questions around, there will be some question around asynchrony or dysynchrony, and for that understanding the triggering is important. So the main two triggers that are used these days is flow trigger, which is mainly in the support mode ventilation, and time trigger, which is in the control mode ventilation. So to reiterate, the time triggering is when I have just selected a time after which the next breath is going to be delivered. And this is when we set a respiratory frequency and the inspiratory time. After that time has elapsed, then the next breath has to come. So that is time triggering. And flow triggering is mostly in the support mode ventilation, where the inspiratory flow falls it falls to maybe 20% of the highest flow, then the next breath comes. So that is flow trigger, and these are the main ones that are used, and there are others that are on the slide, but these are the two main ones that we will think about. And I will talk a bit more about asynchronous arising from problem with triggering, and this concept will come back then. And similarly, cycling. What kind of defines what a breathing cycle is? Again, time is the main one. And for example, if we are setting a time of say 20 breaths per minute, that means after 3 seconds that breath stops. But even before that, if we are putting a inspiratory time of 1 second, then after that 1 second, the time, the inspiration has to stop, and then the exhalation has to begin. So that is the time cycling, and similarly, flow is used for cycling as well. Equally, and again we'll come back to that. I'm just introducing this so that we can discuss this in the asynchrony related questions or problems. So the initial thing was was an example of a time cycling, and then there is a flow cycling example, which is this figure. Sorry. And again, just so that we are all on the same page, and I know people of various experiences are there. That's why for some it's quite basic, but we just want to make sure that we all have this equal and same understanding. So when we are creating a volume controlled setting, then the things that we will need to have is this FiO2, obviously, and then we need to set a tidal volume, and then we need to set a respiratory rate. This is, we all know that. And then eventually we'll also need to have a inspiratory time within that that respiratory rate, and how much this inspiratory time is going to be, that depends on what sort of lung we are dealing with. Is it a stiff lung or an obstructed lung? And I'll give example later on. And obviously, when you have set a volume, then the thing that changes with breath to breath is the pressure. And we obviously have to keep an eye on what the pressure is, because we don't want to deliver too much pressure there. And alongside this, you can see that there is a PEEP as well, which we have to deliver a PEEP. And this is an example that has been taken some time ago. You can see that this PEEP is probably a bit high for the FiO2 that is there for 40%. Again, that gives us a chance to think about the PEEP table that ARTSNet had initially in the very first low volume strategy trial that changed practice in ICU. So usually for 40%, 11 of PEEP is probably not quite right. It has to come down, but that's an issue that we can discuss nicely with this particular picture. And now if we think of a pressure control, I am deliberately avoiding use the other part of the nomenclature, which is BiPAP, because as we know that this is a trade name. So we just think of pressure control. And again, for any ventilatory mode, we have to use FiO2, and then P inspiratory pressure, and then again respiratory rate and inspiratory time. So instead of volume, we chose inspiratory pressure, and then rest of them are more or less the same. And then what changes obviously is the volume, and we have to keep in mind that the volume isn't too high, and we have to obviously know the ideal body weight of the patient to know what volume is good for this particular patient. If this patient is a small, frail elderly lady with a predicted body weight of 50 kilo, this is quite high. On the other hand, if it's a tall gentleman who is predicted weight of 75, it is still a bit high, but it may not be that bad. So these are the basic, and again we talk about PEEP, and here we see that PEEP is 8, and probably not that bad compared to the other one. 35% with a PEEP of 8 is we can think about maybe reducing it a bit more, but not too much. Again, we need to remind ourselves we're not obviously talking about teaching how to ventilate patients. I'm just setting the scene up for subsequent discussions. And this slide isn't particularly good, but this is a spontaneously ventilating patient with pressure support. Unlike the previous ventilator screen, there are quite a low amount of dials here. Only all we decide is what FiO2 is needed, what PEEP is needed, and what pressure support is needed. That's all. And then we keep looking at various things. So that's the basic stuff that we do regularly with our patients in the ICU. And then there are other modes as well, like APRV, etc. But I don't think that will be that important for the exam itself. So I haven't included any slide for that in this particular section. Now, there are some concepts and some questions that come. When I did my EDIC 1 some time ago, I certainly had a question around this. So just to introduce this topic, this issue, that we all know pressure volume curve, and we all know that there is a separation between the inspiratory curve and the expiratory curve. The lower one is the inspiratory curve, as you know, and the upper one is the expiratory curve. And there might be some questions around it, but before that, how it helps in understanding what sort of lung we are dealing with when we are ventilating someone. I thought I'll just introduce this, that if we think of the lung as a balloon, right at the bottom of the pressure volume curve, the lung units are quite collapsed and quite small, and we are adding air pressure to inflate the lung. And then as we go past the lower inflection point, the compliance is quite good, and it inflates quite nicely immediately after that. So the PEEP has to be somewhere here. Obviously, we don't use this to know what our PEEP is. We use other methods to understand what the PEEP should be. But this conceptually, it is important to always think in these lines. So as soon as we go past that lower inflection point, the balloon is much more easily inflatable, because the compliance is much better, and lung is inflated quite nicely around this part of the curve. But if we keep pushing it further, then right at the height of the as the pressure goes up, then it is overstretched, and then lung injury obviously is much more likely to happen because stretch is not good. And the gap between these two curves is called hysteresis, and I'll come back to that. And this is a very easy question to have, and they like to ask this particularly, and you need to know why hysteresis happen as well, and I'll mention that later on. So some terminology, we need to know what peak inspiratory pressure is. So that's the peak pressure that is found in the respiratory, in the breathing circuit during the inspiratory phase. Mean airway pressure is the average of throughout the respiratory cycle. And then positive end expiratory pressure, we know it's PEEP, and plateau pressure, auto PEEP, will come back to that in a minute. But there certainly will be question around plateau pressure, auto PEEP, and possibly time constant as well. The top ones, they're fairly basic, and probably there is not going to be much question around that, but they will allude to these pressures whilst forming a question. That is more likely. So this is how it looks, and we all have to understand this very well. And it is something we see all the time, but we just have to know that just have to know this very well. So this is the pressure time curve, and peak pressure is right at the top, the maximum pressure during inspiration, and then there is a drop, and a lot of us know that is due to the resistance at the airway level, and then where it plateaus, that is plateau pressure, and then it drops to PEEP if it doesn't drop to zero. And obviously we have to be very, we have all of us have to know, and I'm sure all of us know, that plateau pressure is measured by doing an end inspiratory breath hold. End inspiratory breath hold gives us plateau pressure, because if we hold the breath at the end of inspiration, then the pressure in the whole of breathing circuit equilibrates. So the sensor is distal to the patient, and therefore if we just measure the pressure at the sensor level, then it's not going to measure the plateau pressure, which is at the level of alveolus. That is the level where the plateau pressure is we're talking about plateau pressure at the level of alveoli. So it has to equilibrate to the airway level for us to measure it. That is only possible when we have stopped breathing for a while. and give the chance for the pressure to equilibrate. Now, I'm spending some time discussing this because this is asked, but quite importantly, there are a couple of issues there. I don't know, but there might be question. So I want to mention two things. It's not in the slide. If the inspiratory breath hold is done quite for a very short period, for say half a second or thereabouts, there is a chance that the pressure didn't drop all the way to the plateau pressure, and the pressure that we get might be overestimated at around that level. And equally, if we hold the breath for more than 2 seconds and longer, then what might happen is, as we know, that some lung segments, not every lung segment get filled with air equally. Different lung segments have different compliance and so on. So what might happen, that longer inspiratory breath hold, if we are breath holding longer, then what might happen is that that equilibration within the lung segments might happen, and there might be a pressure drop within the lung. So in that situation, what pressure we get might be lower than the actual plateau pressure that we should measure. So too short is bad and too long is bad as well. And that it might be a topic of question as to what would be the implication if the breath hold was shorter or longer than required. And that is the concept that one needs to understand. We all know an inspiratory breath hold is needed for plateau pressure, but shorter or longer breath hold might be bad in measuring it. So I thought I'll mention that. And then when we talk about auto-PEEP, as a lot of us know, is the failure of lung segments to clear themselves completely or empty themselves completely, and therefore because of buildup of air at the end of expiration, because the closing volume, etc., that there might be buildup of air, and that generates positive pressure inside when there should not be. And that is important because for a control breath, and more so for support breath, for the patient it is difficult to generate any meaningful breath if the auto-PEEP is too high. And we have to measure this, especially in the context of obstructed lungs in COPD, asthma, etc. And the way we measure auto-PEEP is highlighted there, which is end expiratory breath hold, opposite to plateau pressure. And we do an end expiratory breath hold. It's important because if a patient is self-ventilating or spontaneously breathing, then they have to generate a lot of pressure to get to a position where they can generate airflow from. So because they have to drop all the way from there to here, which is longer journey in terms of pressure generation, the muscles fatigue quite badly. So auto-PEEP is important, and it is to be measured, and we measure it by end expiratory breath hold. Now, for both plateau pressure and auto-PEEP measurement, it is in ideal circumstances, it is not enough just to do end inspiratory or end expiratory breath hold. What is important also, again, this is not always doable or done, but ideally for exam scenarios, it has to be done in a properly deeply sedated patient or a paralyzed patient, because you don't want the patient to add to any pressure within the chest, because otherwise it will falsely measure these pressures. So that's the question. That is another factor that has to be remembered. And auto-PEEP works this way. So various lung segments work differently. So this segment has cleared itself quite well, but these other segments have not done it very well. And therefore, when we talk about auto-PEEP, it can be different in various different lung regions, and we alluded to previously as well. So this is something that affects various regions in a different way. Compliance, we know from physiology days, there are two types of compliance mainly, static and dynamic. And static is something that we can't really measure. It is a compliance in absence of flow. So, and this is contributed by the chest wall compliance and lung tissue compliance. So lung tissue issues with chest wall and lung tissue. but this is not something that can be easily measured. What we end up measuring mostly is the dynamic compliance, and it is the change in volume for per unit change in pressure. And therefore, essentially, you will have to see what the tidal volume is and divide it by the driving pressure. That kind of gives you some kind of dynamic compliance, and it changes breath to breath always. And the factor that is additional on top of the static compliance in dynamic compliance is the airway resistance, obviously. And if the airway resistance is very high, then the compliance is obviously affected. And then we again come back to this hysteresis point, the difference between expiratory and inspiratory compliance. That is essentially hysteresis. And why is it that the expiratory in the expiratory part, the volume is somewhat higher than for the same pressure than the inspiratory limb? There are various different reasons. The surfactant is one reason. The way the lung segments empty themselves is another reason, and the collapsibility of lung tissue is another reason. And some of these might come. I haven't put it in the slide, but cause of hysteresis, if we can have a look, and then there are 3 or 4 different causes that causes the both the limbs not to superimpose on each other. Time constant is a question that comes and may come, and there are a lot to discuss, but just very briefly, it's time needed to fill in or empty any lung unit. And every single lung unit have their own time constants, but you can't measure each unit as individually. So you have to measure the whole lung together, but you have to understand that each lung units work differently. And this, although it says that time needed to fill in or empty a lung unit, mathematically speaking, it is the time needed to fill about 63% volume of any lung unit. That's because when lung unit tries to empty itself, it is not a linear function; it is an exponential function. But the way it is measured, it's at 1 second, and therefore there is an artificiality to it. But for the purpose of this exam, if we remember that this is what it is, and time constant is resistance times compliance, and different time constant for different adjacent lung unit gives rise to Pendeluft, which is another concept that we need to know about for exam, which is if a lung unit has a very low time constant, it tries to empty itself, but the adjacent lung unit has a high time constant. So when this smaller lung unit, so the lung unit with the low time constant has emptied itself, the other one hasn't emptied, so there might be flow between the second one to the first one. So these different time constants cause movement of air between the lung units, and that can cause trouble in terms of lung injury, etc. And therefore, Pendeluft is a thing that happens, and it happens very, very much not only in ventilated patients but also in spontaneously breathing patients. And there are literature around this that talks about high amount of Pendeluft in spontaneously breathing patient, and how spontaneous lung injury can happen as a result of that. And once we have gone through those points, I just wanted to highlight some of basic equations that do come in the exam, which is resistance. We all know that no one is going to ask us to calculate the resistance, but they're usually quite easy question that it might just ask, for example, if the diameter of the ATT is reduced by half, how much will the resistance change? So it's inversely proportional to the fourth power of the radius, and you just have to calculate that. It's 2 times 2 times 2 times 2. It will increase by that. And similarly, Reynolds number, this is a favorite question in any respiratory or anesthesia or critical care like exam. And this is what the Reynolds number is. This decides whether the flow of a gas will be linear through a tube. And therefore, a question might come, if a gas's viscosity is increased, if a highly viscous gas is used, for example, what will happen to the lamellarity of the flow? And if more dense gas is used, what will happen to the laminarity of the flow? And therefore, you can easily use that because Reynolds number is directly proportional to the gas density and inversely proportional to the viscosity. And lower the number, L for L, lower the number, more laminar is the flow. So for a lower number, the flow is more laminar. So essentially, if the viscosity is high, the number will be low, and therefore the flow will be more laminar and better rather than turbulent. So that is something that is often used. Another equation which is often used is the dead space equation, which is VD, which is the dead space divided by tidal volume. And here you've got an arterial PCO2 divided by, minus expiratory, end expiratory CO2 divided by arterial CO2. And so what might happen is that a question might come if PeCO2, which is available to you through the screen, through the monitoring, and you have got a blood gas, and if you know the tidal volume, what is the dead space? And therefore, that this equation is good to know and may come. I think I had something like this when I did it in the past. And shunt equation, I don't think it will come, but especially because it's almost impossible to do it, because you need mixed venous oxygen saturation, but it is something that I suspect anyone talking or reading about lung mechanics, etc., will have to just know. So that's why I've just put it there. Another question, another area that always provides a ground for some questioning is various different pressures, and one can expect to have to calculate what is the transpulmonary pressure, what is the driving pressure, and so on. The most important is the transpulmonary pressure, which is essentially this. Transpulmonary pressure is alveolar pressure minus pleural pressure. So alveolar pressure is what? Alveolar pressure is the plateau pressure. Pleural pressure you can't change, you can't get through the ventilator screen. For that, you need to have a esophageal manometer, and that's why these questions usually come in conjunction with an esophageal manometry reading. And therefore, if you are given this, then you have to come up with you have to know these equations and come up with the number that is being asked. So transpulmonary pressure is the most important of everything, because that decides ventilator-induced lung injury, and therefore there might be question around that. And then there are obviously other pressures, but usually I would expect that if a question comes, that will be around this. And then there is another concept, which is transpulmonary pressure, but there might be a clinical stem given with a fairly high BMI patient where there is a lot of body wall impedance, and therefore simply knowing the pleural pressure, etc., may not be enough, because the abdominal pressure is causing a massive influence on the mechanics of the lung, and therefore transpulmonary driving pressure is actually, in this situation, plateau pressure minus PEEP, which is the actual driving pressure that you are getting. However, that is not all, because some of that pressure is being used to counter the pressure that is coming from abdomen. So it will, transpulmonary driving pressure will be plateau pressure minus PEEP minus inspiratory esophageal pressure and minus expiratory esophageal pressure, which will be taken from the esophageal manometry. And therefore, one probably will not ask a direct question to calculate the pressure, but to have the concept may be important, that it's simply the pressure that is derived from the ventilator screen may not be all for obese patients. And there have been studies showing that the transpulmonary pressure is not essentially not the driving pressure, but the transpulmonary pressure itself, it is not as high as it might seem from the peak pressure that we get from the ventilator, because a lot of that pressure is being spent to overcome the weight of the body wall. And that is important, and because we would accept a higher peak pressure in obese patients because of this issue. So this is something that to be to be aware of. In various stents, this might appear. And pleural, as we mentioned before, pleural pressure measured by the esophageal pressure. And harms associated with ventilation, I'm not going to repeat that, but barotrauma, volute trauma, biotrauma, atelectotrauma, etc. And there will be a question around this, and especially during COVID, we have seen a lot of not only ventilator-associated trauma, but a lot of pneumomediastinum or pneumothorax as well. That is a barotrauma, almost spontaneously induced as well in spontaneously breathing patients. So in the current context of the pandemic, we can expect that we might get some questions around this. So now with this in the background, I'll just go through 3 patients. Say a 26-year-old gentleman with accidental codeine overdose, a simple normal lung we'll expect, unless they have vomited and aspirated quite a bit, in which case the lungs are abnormal, but say it's not abnormal. So all we need to know in that case is what is the ideal body weight. We have to kind of know this equation for exam. And our target tidal volume is 6 to 8 ml per kilo, male, female, different equation. And then once we have known it, we have to understand, is this lung normal? Is it stiff lung, or is this tight lung? And then we can decide what is the mode or setting we have to use to ventilate these lungs. But for our patient, the first patient, we know that this is a normal, so the compliance will behave quite well in the middle. And therefore, we'll say it's a normal lung compliance, and it just needs normal minute ventilation. And then it's like 100 ml per kilo body weight. And then what setting can we use? Any setting, volume control or pressure controlled, with the volume in mind. What is the target volume? And can be extubated when sufficiently awake. So no problem at all. But then if we have this 60-year-old gentleman with influenza pneumonia related ARDS, and then this is clearly a fairly badly damaged lung. And say when this patient is struggling, then we have to make sure that we ventilate them with care and caution. Otherwise, we'll do quite a lot of damage. So these are all the pathological things that happen. Then it's essentially we are in a low compliance situation, which is the lower curve. We'll need higher pressure, very likely, need higher inspiratory time to inflate something which is very stiff. And but expiration is usually much easier because the lung wants to just come back to its baseline state. And then lung segments tend to collapse easily. That's another thing that we have to know, which I'm sure all of us, most of us know anyway. So my choice will be to get pressure control. And if I were to start high, but come back, titrate down very quickly. Inspiratory pressure, again, you have to titrate, but somewhere between 24 and 28, and high-ish PEEP. Respiratory rate start at 20, but keep a high-ish inspiratory time and look at the flow time curve to decide what is best. So that's we all know that. And just quickly going through what are the other things we have to do. We have to keep them deeply sedated. Oxygen, choose the right one. Low tidal volume is important. PEEP is important. Driving pressure. If we remember that New England Journal paper from 2015, we'll know that driving pressure probably would be more important than what the exact plateau pressure is. And inspiratory time, recruitment, all of this is important. You might be asked about fluid strategy, not initially depending on the overall systemic situation of the patient, but generally not to allow them to be wet or overloaded. Neuromuscular blockade questions there. Initially, there was suggestion that it helps. It still probably helped, but the Rose trial did not show any benefit between the groups. Specific medication, if you have to use any adjunct, then you talk about proning and ECMO. And high PEEP is, I'm sure there would be questions about high PEEP or PEEP setting of a patient. And we just to show that low PEEP causes more inflammation in the base of the lung, as shown in this PET scan, and it just causes more collapsibility of the lung segments, and therefore cyclical stretching, which is bad, which you know about, but I just thought I'll include this particular image here just to give a visual impression. Then PCLE might come. So for a patient like that we just talked about, if we allow that patient to have intermittent spontaneous breath, or even for a patient who has got moderated ARDS and is not ventilated but breathing spontaneously without the aid of ventilator, this cycle can happen, we know, and there is a chance that there might be some question asked about this, how it happens and in which group it might impact more. So initial lung injury, capillary leak, lung edema, that causes more collapse. And then the patient has more drive, increased respiratory drive, that causes more of all these other issues. So by reducing the alveolar pressure, then again, huge amount of tidal volume followed by that, increased swing of the system. And this is quite well-known slide, and I've included that just to highlight that there might be a question around this, and I don't think we know exactly at what point we need to ventilate a patient to prevent PCLE, but there are enough physiological data to suggest that this is a problem that happens in spontaneously breathing patients, and we have to be mindful of that at least we know. And this is a slide from the ROSE trial, again, the neuromuscular blockade trial. And again, this did not show any benefit, but if we do think about this issue, and if a patient is really badly lung damaged and they are taking enough intermittent breath, then that is likely to be harmful. And therefore, in that group, there must be a small group where neuromuscular blockade is helpful. And therefore, although ROSE trial has shown this, this is a physiological concept, I think, to be aware of, that these two are interrelated. Why we need to neuromuscularly block a patient to prevent this, essentially. And therefore, even the ROSE trial has shown no particular benefit at 90 days. There possibly is a small group of patients who have got inherent breathing effort who will be benefited from neuromuscular paralysis. And prone positioning, you have to know this, that this works. We all know, especially after the pandemic. It will be good to know the exact relative benefit that was there between the prone group and supine group. The mortality was about 32% and 16%. So I think it's good to know that how much it is reduced by. Because this is widely known and widely used now, and therefore you kind of have to know for an exam purpose. So now we talked about stiff lung. Now let's talk about the tight lung, just to make sure that we get the points right. So this is a 69-year-old man with severe COPD. Airway resistance means longer expiratory time required. As they say, this person has failed NIV trial and they have to be intubated because they were getting really tired and acidotic. High pressure often required, but a lot of this is to overcome the airway resistance rather than the overall lung. So it will not be translated into high alveolar pressure. Chance of barotrauma high. Why? Because various lung segments might have different compliance, as we discussed before, and therefore even if some alveoli will get fairly low pressure with a high peak pressure, some others may still get fairly high pressure and might essentially cause pneumothorax, etc. And obviously we have to treat the lungs, and this is a point that has to be remembered, because there might be a question with a ventilator setting with a patient like that, and then saying what else can we do, and often there might be a missing point in the medical management. Say there might be nebulizing, etc., but steroid is missing. So that would be the answer that they would want. So my choice would be pressure control again. If I were to start high, quickly come down, I'm sure these patients never need 100%. Usually they're between 40 to 50% at the most. And PINSPOF, say we start at 24 and over 6, we have to make sure that we have a I ratio which is with a longer E component. longer expiratory component. That's important. And if this did not work, sometimes they want this answer. If this fails and everything else is okay, medically managing this patient, what else, what more can you do? What would be the next step? And that would be, if CO2 clearance problematic despite all of this, then we reduce the respiratory rate further to 10 to 12. Some might say up to even 8 per minute, and increasing TI slightly, because the TI that we give with a poor lung compliance, some segment will have bad compliance. We will not achieve any good tidal volume. So increase TI to aid achieving a better tidal volume without compromising not CO, but CO2 clearance by having prolonged respiratory time. So this is something that they might ask as to, if the initial strategy fails, then we'd go down on the respiratory rate with a good I ratio maintained still. So this can be a favorite area that they might ask questions about. And then 2 winning numbers. This is again used quite a lot in exams, so I mentioned it here. P 0.1, which is the airway occlusion pressure. This is a pressure developed in the occluded airway about 0.1 second after the onset of inspiration. So what happens is, by this we measure how much is the drive, respiratory drive of the patient. So this is how it's measured. This is a patient, essentially this in expiration is stopping there, and within 0.1 seconds we are occluding the airway and measuring what is the pressure being generated by the patient. In this one it's 3.8, in this one it's 0.7. It's very low. It's very low. So this patient is not really trying that hard, and there might be quite a few reasons for that, which might be in a question. They might ask, okay, what can you do? So maybe the patient is on a high amount of sedation, or maybe simply the muscle strength is just not there, and we have to build the muscle from here. But another context it is used, which is if the pressure is too high, it's very high, that means the respiratory drive is very high, and the patient may not cope by breathing spontaneously by themselves. So anything above 6 is a cause of concern, that the patient is trying too hard. When the patient is breathing more or less conveniently, they will be somewhere between around 2, 3, 4, around that number. But anything above 6 will suggest that it is too high, and I'll be worried about this patient. If we want to extubate, etc., it may not be feasible. Or if we decide that, okay, I'll just keep this patient on pressure support mode for a while, it will be problematic. We have to do something. Essentially, it's not ideal to leave that much of respiratory drive in the patient. And then a rapid shallow breathing index. It's a very easy exam question. It is essentially respiratory rate divided by tidal volume. And therefore, for a patient with tidal volume of 200 with a rate of 30, its RSBI is 150. It's just basic arithmetic. And the number we are looking for is 105 breaths. If it's more than 105 breaths per minute per liter, it's highly predictive of winning failure, because the patient is breathing too fast to generate too small a tidal volume. They're not ready. So RSBI is another one that is often used in exam questions, and it is easy to remember and answer. And there is a favorite topic in any exam. EDIC certainly has it in various different forms. They will give different flow time curve mostly, or sometimes pressure curves as well. And they will say that the patient is uncomfortable, what is happening? And then one has to identify. So patient ventilator asynchrony usually obviously happen when the patient is breathing, and therefore either in assist mode or in support mode. And it can be associated with adverse outcome, not only by making the patient tired and by prolonging the ventilatory time. So ventilator free days will be low, but also by increasing mortality, because when the patient is not in total harmony with the machine, then they will try hard and they will cause a lung injury as a result. And in some studies, there can be 2 to 3 times increased mortality when there have been patient ventilator asynchrony. And so I'll just talk about a few types of different asynchrony, so you are aware, and so you can work out what is given in the question. So triggering first of all, we talked about trigger at the very beginning. So there are various types of trigger. Flow trigger, time trigger are the two most common ones. And there could be triggering asynchrony. Number one, the patient may fail to trigger. Here you have got an example where the patient is triggering quite nicely. This patient has got esophageal pressure, and this essentially finds out when the pleural pressure goes slightly down. So the patient is trying to breathe. For every effort, it's followed by a ventilator given breath, and this is perfect. This is how it should be. So there is no failure here. But if we take this example, we see that in the flow time curve, there is slightly some intermittent upstrokes. So or in the pressure curve, there is some downstroke when they're on the expiratory limb. That means the patient is trying to breathe here, and during this time, this is not associated with the next breath. So they are not generating enough pressure or flow rather to cause initiate the next breath. And so if there is something like this, that will mean that there is a failure to trigger. And so this is kind of a schematic diagram. It might look on the ventilator monitor something like this. There are quite a few upstrokes, but it's not quite reaching the point where the next breath is being generated. And so if a question comes that the patient looks uncomfortable, and this is what the trace looks like, and what are the next options, and depending on that you can choose. Usually the answer to this would be to reduce the sedation, to change the position of the patient, maybe sometimes to make sure that the flow trigger is not too high. If it's too high, if you reduce it, then the machine will be triggered by a lower flow, and then that might be an answer. So this is a failure to trigger, which can cause asynchrony. Now, auto triggering, this can happen due to very strong cardiac oscillation, or if there are a lot of fluid in the circuit. Because of the oscillation of the fluid itself, that flow can be disturbed, and that can itself generate lots of triggering. When the patient is not ready, suddenly, artificially, there might be slight pressure drop or some flow generation in the circuit, and therefore that will trigger the next breath. And this will be associated mostly with continuous up and down strokes of the pressure in the pressure time curve, and similarly the flow curve. And suddenly what's happening is one of them is sufficient enough to generate the next one. In this case, the patient probably wants to breathe 15 times a minute, but because of this issue, without the patient's control, multiple extra breaths are happening, and you can imagine how uncomfortable that will be. So often an answer to this might be to clear the circuit of any water that is there. If it's a cardiac oscillation causing the trouble, I suspect you can't do much about that itself. Then you have to again see whether you can adjust the trigger slightly differently, so that much of oscillation does not trigger the next breath. Now, the flow asynchrony, it can be either due to inadequate flow or excessive flow. And inadequate flow will be, for example, when the air hunger of the patient is going over what the machine can generate. And the way it is identified is to be honest, it's not something that is often seen, but especially in the pressure control mode, if it's on an assist mode. But the way it should be identified is this, that when the patient is trying to when the machine is trying to give a breath, so it's an inspiratory limb, then the patient is going over it to create some more negative pressure, and because he or she wants more. So, and sometimes it will just cause that much of a concavity, but the flow will not hugely change in response to that. So this is how it should look. That's a kind of inadequate flow trace, and this is how it will look on the actual ventilator. This is again a schematic diagram. So here, this is the overall this inspiratory limb of the pressure, but here the patient is creating some concavity by pulling air in. by pulling it towards negative pressure, and this is how it looks like. That would be, then the flow has to be increased, or if it happens, that often it is because the patient is pyrexial or in pain or in some kind of other discomfort as well. So if we can treat those things, then the immediate air hunger will go down and it will be solved to some extent. And then excessive flow can also obviously happen. And then excessive flow will be when the machine wants to give more than what is needed, what is required by the patient. And that is often created by this immediate initial pressure spike. And this is often not a huge problem. I suspect this is not going to be asked, this particular one. And this is how it looks like in the actual ventilator screen, the initial high spike of the pressure curve, pressure time curve. And then cycling asynchrony, early cycling, this can happen depending on what time, frequency, etc. we are choosing. So it can be early cycling. So essentially, we have a situation where the patient wants to continue to breathe in, but because of the time cycling that we have chosen, the inspiration has stopped, but the patient wants to still breathe. So what is happening is during the exhalation, the patient wants to breathe here, and therefore there is a deflection at the beginning of the exhalation, that the patient wants to keep breathing in, but the machine wants to breathe out, and that's obviously very uncomfortable situation for the patient. So that is cycling asynchrony, or you just have to increase the inspiratory time in that case, and this is how it will look. So during the initial part of the exhalation, it is going upwards. The flow is going upwards because the patient keeps breathing against the machine, and so that is if we can increase the inspiratory time all the way up to here, maybe then the patient would have satisfied with the overall breathing effort, and then they will not try to fight the ventilator there. And delayed cycling is exactly the opposite, where the patient wants to breathe out, but the machine is still breathing in. And therefore there is an asynchrony, and that is obviously exactly the opposite in the curve. It's right at the end, the patient wants to breathe out. So they're causing more positive pressure inside the chest, and there is a little bit of upstroke right at the end of the pressure curve. And in this situation, we just shorten the inspiratory time. And the way it might look on the actual ventilator screen is this: right at the end, there is an upward spike, and we have to reduce the TI to overcome this. So that is cycling asynchrony. And again, this is purely how we set the overall machine that is causing the trouble. And obviously we know that in practical situation, when you have looked at it and you can't solve it, to understand the situation better, often we sedate the patient, and sometimes we have to paralyze. But in the exam scenario, they will want the candidate to identify what is going on and solve physiologically. And that's why these issues have to be understood. And then there is a thing called peak pressure apnea, which is more by alarm. We can set an alarm of, say, we will not allow the peak pressure to go beyond a certain level. So we might have set a tidal volume of 500 mLs, but the peak pressure, say, somehow has been set at maximum peak pressure 35 centimeter of water. And at that point, the patient might have got 300 ml tidal volume. So the more peak pressure is needed for whatever reason, airway obstruction, etc. But it will obviously stop at that point because the peak pressure is reached without delivering the volume that was intended. And then there's a bit of apneic phase because of this situation. So this is called peak pressure apnea, which is more asynchrony with the alarm or the limits that we have set in the machine. So we can expect at least one question from this area. And to conclude, we have come to about 55 minutes. So we just need to remember that the basic ventilatory strategy, we just have to get it right, and how to measure different pressures, we have to get it right, transpulmonary pressure, etc. And we have to remember that basic respiratory equations, we will get a question from those, the ones that I mentioned, maybe some more I haven't mentioned, Laplace's law, etc. And then the types of dysynchrony, there will be some questions there. So we have to prepare for these. And I have not talked about non-invasive ventilation, because that's a separate topic as a whole, and you can ask me questions on this email. Okay, I mean, I initially said, oh, Robin wants to ask something. I think he has got a hands up. Yeah, go for it.
As of now, sir, there is a question from Dr. Ankur to explain the difference between TRP and TMAS.
Robin is missed. So, as I said, the transpulmonary pressure is purely when they ask the question, you are looking for they will, if they ask the question, they will probably put something like they will give a value, or they will give a plot, or they will give either the value of the plateau pressure, or even in the plot there will be something in the plot that you can work out what the plateau pressure is, and they will give the pleural pressure directly, or they will give the esophageal pressure, and from that you just have to measure that. So essentially, the pleural pressure, alveolar pressure minus the pleural pressure is the transpulmonary pressure, and T muscular is obviously the pressure. I'm just going back to this slide that is there. So essentially, that is what the muscle overall generates to that is the part of the thoracic effort that is outside the domain of the pulmonary area. So usually they will not really ask the question. So it's a different, that will be delivered through the to the diaphragm and the intercostal muscle, and depending on the situation, the abdominal muscles as well. And this is not something that you will be asked to measure. You will have to, from all the numbers that is given, if you identify which one reflects the pleural pressure and which one reflects the plateau pressure, you just work out the transpulmonary pressure, because that is what is important for the lung damage. And usually the question is asked around that. So if you could identify that, then that should be probably okay. So the following graph represents the end-tidal volume, end-tidal carbon dioxide pressure, airway pressure, flow, volume, and esophageal pressure during 3 different modes of mechanical ventilation: A, B, C, D, E, F. A, B, C, D, E, F. Okay. For column EF, the mode of mechanical ventilation is, okay, pleural.
Sir, for the benefit of everybody, would I like to share the screen of the question, and I'll share it over here?
So
you tell me to scroll it, I'll scroll it for you.
No, I can see it now. I know the question. So so that is the airway pressure. The top one is P. Flow is there. A, B, C. So here, so airway, the initially still. Can you read out what is there on the top? The pressures. What are the pressures? So one is there is the bottom one.
Because if I'm screen sharing, I can't do this actually. Okay, 1 second.
I can read the type of pressure in one of them, so that's why it will be easier to.
Shweta? Yeah.
So the first waveform is of end-tidal carbon dioxide. Okay.
Okay. Yeah.
The second one is the airway pressure. Third is flow. Fourth is volume, and the fifth one is esophageal pressure.
Okay. So please, that bit I couldn't read. Fifth one is esophageal pressure.
Yeah.
And esophageal. So obviously carbon dioxide isn't going to help here at all. So you can totally disregard that. There is not. So essentially it will be between if we look at the esophageal pressure, what's happening is AB, it is going to quite a bit positive in the first one. So A, B, 3 more. So in the esophageal pressure goes quite positive towards the end of that on the B, and if it is not going quite a bit positive, and this is associated with second one is airway pressure. So that one is flow is going plus and
So there are
one
actually
thing is
three
one
questions.
one thing is for sure in F. What's happening is there is a negative downstroke in at the
Yeah.
beginning of the breath in the airway. So essentially, this is not going to be a fully controlled mode, and neurally adjusted. It's very hard to know because there is nothing given in terms of there is no EMG data or anything like that. So it's that is out immediately.
Okay.
Given the fact that the patient is creating a negative pressure towards the beginning of the pressure curve, that means that there is some kind of patient effort associated with it, and therefore it will be one of the situations where the patient is has an effort. So it will either be one of them. So pressure support or assist AVC or proportional assist. So it will be probably either the volume control or pressure support. So let's analyze if it's a volume controlled breath, what happens to the flow. In the flow, usually you get there is no kind of decelerated pattern of the flow. So let's see what happens in the flow in this one. So flow is, it's not coming down usually, so more or less the same flow. I think it is going to be pressure support, and that's how it looks like, to be honest. Is that the answer?
I don't know what's the answer, sir. There are three questions in this segment. There is one question on what is AB. There is another question on what is CD and what is EF. So this was one question.
EF looks to me as if it is most likely a pressure support mode. Because like I said, there is a negative pressure being created right at the beginning. So there is a patient effort. And then if it's a volume control, then in the flow kind of stays the same, more or less for the time of the inspiration. And it is more or less the same. So there is a little bit of a downstroke in the flow there. And so I think it is most likely pressure support. I might be wrong, but that's how it seems to me.
Yes, sir. I'll just check it, sir. Even I don't know what's the answer. The AB one was AB segment. What about the AB and the CD segment, sir? There are two more questions on the same.
Yeah. So for column AB and CD.
And CD, yeah.
What I'm not getting is what is the difference between A and B and C and D and E and F?
They look almost the same. That's why.
No, I mean, not only the same, but I mean, the pairs are looking the same, but what is the difference between A and B? If it's the same mode, what is the difference between A and B? That is the bit I'm trying to understand, because A is different and B is different in the pressure or flow curve. but they're the same patient and same mode. So why is that? Unless
There are different modes, sir, during 3 different modes of mechanical ventilation.
I know, but the 3 different mode is AB. AB is one mode, A and B. So what they're saying is, following graph represent end-tidal CO2, airway pressure, flow, volume, and esophageal pressure during 3 different modes of mechanical ventilation. So one mode is AB, the other one is CD, the other one is EF.
Yeah.
So it's not like A and B are different. AB is one, CD is one, and EF is one. But why is it that they're looking so much different? And that bit I don't understand. And then I also said that in the first one, there are quite a few other things that you use. For example, if you look at the flow curve,
there is one sentence. There is ACE at baseline. So ACE is the patient's baseline. That is just above the image. There is one.
Yeah, that's right.
So ACE is the patient's baseline. Yeah. So B, D, and F is when you have changed the mode to something, I think.
That's a very bad question. I mean, baseline at what? I mean, this one, the EF, I think it is going to be pressure support. There are other things going on there. For example, the flow curve is different to each other. There is this one very small one, etc. So the flow, this will not change if it's a controlled mode. If you look at the flow for F, then there is a one very small one. So it is changing. That's because there is some patient effort associated with it. And that's why I'm saying that it's a plus the negative pressure. That's why it looks to me a pressure control, and generally it looks that way. But I don't understand what do they mean by baseline? What is baseline? Unless there is a previous stem where they have said that the baseline is volume control for everything or whatever, and then they're expanding on those questions later on. This is not. I'd say that this is not going to be a standard EDIC style question. I can't answer the whole thing. This EF, I think I'm pretty sure that it's looking at pressure support.
Yes, more. The ACE module, sir, of ESIC.
So, ESIC, but some of these things they haven't updated for a while.
Okay.
And so I doubt that this kind of, if they would clearly say this is a very cumbersome way to present a question.
Yes.
A baseline, if we say at question between question 10 to 15 that for all these following patients, the initial baseline mode was volume controlled, and then we have made some changes, and then something happens, then it makes sense. But here they're not saying what do they mean by baseline. If I find something, I'll get back to Sudeshna, because I know someone who knows the ESICM style probably slightly better than me. If he can come up with something, I'll pass it on to her and she can pass it on to you.
Yes, sir. Thank you.
As to what is the baseline, what does baseline mean in ESICM world? I don't know.
Thank you, sir.
Thank you, sir. I'll stop sharing. I think there is some more questions. Okay, it's all by Dr. Shweta. So she had answered, she had all discussed. Okay. So any more questions? I think we can end the session here, sir. Thank you so much.
Okay. I think Ankush said that, yeah, he also needs to discuss this. Please unmute me. First wave can give us clue to solve. But I don't know what the baseline is. Is that what you
I'll
meant?
just unmute Dr. Ankur. 1 second.
Yeah.
Hello.
Yes, Dr. Ankur.
Sir, I don't know if I'm right or wrong, but if we can see the first wave of esophageal pressure, and if we can trace it for all the graphs which are given there. So in all the three are different. If in first, what is happening, what I can see that if esophageal pressure is going down, volume is going down, another one is showing flow going up, and like this we can make out. The first one, it is not possible in going subsequently. The first wave where the esophageal pressure of any means B, D and F, the first wave of esophageal pressure, when it drops, what is happening in the above pressures, flow, volume, and pressure. That can give us a clue. I think that must be the key to solve, if we can try that.
But what is not clear as to when it changes from A to B and C to D and E to F? What is it that's happening? Is it that are they trying to say that they're paralyzing the patient? At that point, it doesn't appear to be the case, because the pressures are still going downwards.
Is there any way to share an image from my side? Is there a possibility?
Yeah. You should be able to share it.
Yes, you can share it.
Just give me a second. I am finding. I think that will help us a lot.
So is it possible for you to share it with me?
Just go to this video and go to 4.33 minute. There is an image which shows volume assist control and pressure assist control diagram, where they see, once you share that, then I'll be able to explain it. On this video at 4.33 seconds, there is an image showing graph of volume control versus esophageal pressure control versus. So 4.33 seconds. So what is happening in the first, if the esophageal pressure goes down, and then in volume control, the pressure also goes down. So both the graphs show a dip.
How many seconds? Just tell me.
4.33. So what is happening in this? If esophageal pressure goes down, then the in volume control pressure also goes down. So this is a volume control, because volume remains the same, the pressure drops. But in pressure control, the pressure remains the same. Even if the esophageal pressure goes down, volume gets increased. So like this, we can trace on those graph B, D, E, what is happening to flow and volume and pressure when we are tracing the negative esophageal from the first wave down upwards. That's if we can see that image.
That is understandable, but what is not clear is to what is happening between C and D and E and F and A and B. That I know what you mean, but what is the difference between A and B? What happened between that A changed to B? That bit is not quite clear. And what happened that C changed to D? Let me do something. Let me look at it, and let's see if I can make sense. Because it's not this particular question that you need to have answer for. You need to have a rationale as to, so that you can answer the question, similar questions later on. So let me have a look at it, and let me see what do they mean by. I'm sure I'll find the answer to that. I'll share with Sudeshna, and she can share with you. Because I need to clear my head as to what is happening between A and B and C and D and E and F. And then I can explain the whole thing. So let me spend a few minutes, or a couple, half an hour on this. I will then let Sudeshna know, and she probably has your contact, and she can share with you. Yeah, I'll get back. I'll get back.
Okay. Thank you so much. Thank you. And Dr. Ankur, request you to share this YouTube link with me in WhatsApp.
I've got it. I've got it.
Actually, Dr. Shweta is also interested. So that's the reason, I can share it with the team, and it will be easier for us when we upload the recorded session. Okay. Thank you, Dr. Rahul. And thank you, everybody. Good night. And we will let you know about the next class very soon. Thanks, sir. Thank you.